Welcome everyone, and welcome to this morning's discussion on publication of the NHS Health Bill. I'm Lee Peart, Editor of Healthcare Management. We are a digital publication focused on supporting integrated healthcare. We're delighted to have such a prestigious panel to discuss today's topic. And I'd just like to start by asking you each to introduce yourselves. We'll go with you, David, first.
Hi there, I'm David Williams. I'm Deputy Director of Policy at the NHS Alliance.
And Anne.
Hi there, I'm Anne Hepworth. I'm Chief Strategy Officer at Barts NHS Trust.
And finally, Adie.
Hi there, I'm Adie Perry. I'm Deputy Chief Exec at Cornwall Partnership.
Yeah, that's great. Thanks to everyone. So with last month's publication of the Health Bill, the government set in motion the legislative process to approve NHS reorganisation. The bill includes the abolition of NHS England and Health Watch, the transfer of HSSIB functions to the CQC, establishing NHS Foundation Trusts, the formal transfer of primary care services to ICBs, and adding mayoral representatives to ICBs, as well as the creation of a single patient record. Looking at these proposals individually, could we just start by looking at NHS England and Health Watch abolition? Could we start with you, maybe, Anne, and just ask you for your thoughts on the potential of over-centralising control at the DHSC?
Yeah, so the health bill is massive in terms of change, isn't it? It's possibly the biggest change constitutionally since 2012, and I'm not sure it's kind of hit everybody across health and healthcare quite yet in terms of the massive change. I think around that and that centralising control of DHSC and the impact on patients, I think that there's a number of layers to that. I mean, firstly, there is something about centralising things within the Department of Health and social care, and whether healthcare just kind of overwhelms the health and the social care element of that. And then, yeah, secondly, that does feel like a big machine for patients to kind of connect into. So I think that there is something about, there is a risk there. And how it's actually structured, how that actually rolls out, it's going to be really important in terms of that engagement of the public in health.
That's great. Thanks, Anne. Get your thoughts on that, Adie?
I think Anne's made some good points there. I think it is a monumental change, and the pace at which people are, there are the expectations of this trying to get out there and actually into the running of how we all do business. I think is very, very tight and very, very ambitious. I think there is a danger of things being centralised, but I think also what that would bring, or what that does bring, I believe, is actually a bit more direction as well. So you know, you're not getting a number of different people interpreting things in a number of different ways, and I think that clarity and some more objectivity would actually help. So I'm saying that from a provider perspective, but I think that would give us a bit better direction and a clearer vision.
What about you, David? What's the view of the Alliance?
Yeah, I think there's I think it would be really interested in Anne and Adie's views on the sort of how they feel like the lived reality of this might, what it actually might feel like in real life. But I'll give a policy answer. So the NHS is already really, really centralised. For a health system serving, in England, over 50 million people, it is unusual for, compared to other countries, for there to be a central agency and for there to be so much sort of as much direct political accountability as there currently is. And it's worth remembering that NHS England was set up by Andrew Lansley, but NHS England in its current form, which brings together digital functions, regulatory functions, the commissioning oversight stuff, and direct commissioning as well, it's only existed since 2022. So for NHS England to have as much as it currently holds is actually quite a new development. And people do make the criticism of the new bill that it centralises things by taking out NHS England, taking out the arm's length body and transferring its function to the Secretary of State. It's just worth kind of putting that in the context of it's already a really centralised system. So really what we're doing is taking something that's already very, very centralised and sort of moving the thing that things are centralised on to the Secretary of State. I think there is absolutely, we've heard from members the point that Adie just made about clarity. So you don't necessarily have like two sets of people telling you what the priorities are, and there being the risk of there being contradictions and clashes between that. Although actually people would say that sometimes NHS England has contradicted itself, like because it's so big, different bits of it sometimes give conflicting directions. So I don't think moving things to the Secretary of State necessarily reduces the risk of that. There is what we need to be really careful of in doing that is two things. One is that we don't create in the Secretary of State a set of kind of contradictory functions or aims that sometimes cut across each other or are seen, or where one is seen to be interfering with the other. So what we don't want, for example, is regulatory decisions, decisions like, whether to intervene in a trust or an ICB under the oversight framework. We don't want that to be seen to be a political decision or influenced by political considerations, and we don't want it to be those sorts of decisions to be conflated with the oversight of the commissioning system, for example. There needs to be separation of powers, and that's perfectly compatible with the centralisation that arguably they're doing. That's the first thing. Second thing is that ministers will say that we're already accountable for the NHS, so what we need to do is just clarify that accountability, and there's a reasonable argument to be made there. But what we don't want that to translate into is too much direction and grip. So I don't think this is going to work if the result of it is a more top-down system, a more kind of centrally directed system. We need to be able to do this at the same time as embedding more devolution of decision making and more autonomy down to people doing jobs like Anne's and Adie's, because otherwise a well-run NHS can't be fully directed from the top.
Yeah, I agree with that, and certainly that's one of the things that we're interested to see how that actually pans out, and that will depend on a number of things in terms of the tone of government around that, and the desire to kind of step into that. There's the other side of it as well. So I remember working pre-2012 within the system, and the amount of briefing that had to go up was just so time consuming as well. And whether the ICBs, for example, are kind of set up and have the capacity and the bandwidth to be able to do all of that, I think is another thing that would be quite interesting just to see how that rolls out.
That's great. Yeah, thanks for that. So obviously, there's obviously been criticism that this could be perhaps shifting the furniture unnecessarily, but I think you've made the case that there could be some benefits in terms of accountability and more clarity. We've actually got James. I'll just admit James now. He's a little bit delayed, but we'll bring him in.
Hello, I'm
Morning,
so sorry.
James.
Morning.
It's good. Better late than never. It's good. I'm pleased you've arrived.
It's been one of those mornings.
Yeah, well, thanks for attending. We've just done our intros. I guess if you wouldn't mind introducing yourself, James.
Colleagues, James Benson, Chief Exec, CLCH.
I guess, would you like to do your intros as well, Anne and David and Adie? You may know each other. Do you all know each other already, or?
Yeah, so James, Anne, I'm Chief Strategy Officer at Barts Health.
Hi, James. I'm Adie Perry, Deputy Chief Exec at Cornwall Partnership.
And I'm David Williams. I'm Deputy Director of Policy at the Alliance.
Yep.
Yeah, that's great. Thanks, James. We were just actually discussing the abolition of NHS England and Health Watch, and just debating whether this was going to lead to over centralisation of the healthcare policy. So I'd just like to get your thoughts initially on that.
So, well, by virtue of the fact that the NHS under the Modernisation Bill will be under direct management from the Secretary of State, I suspect we have to admit that this is quite a shift back to central leadership and control. I suspect what we need to watch for in the bill is whether or not the permanent secretary is the same post as the chief exec of the NHS, because it's more that position, I think, is the centralisation rather than the sovereignty of the Secretary of State. In some conversations and briefings, certainly through the Lords, I suspect that there's no possible way that they would want to allow that to occur, notwithstanding the fact that if we consider what a next election would look like, I think the government needs to be very careful about anything that centralises NHS delivery under both the Secretary of State and a permanent secretary. I'm not going to people's own political views, but any party in majority should not have that power, I suspect, because I don't think it's good governance and good leadership. In terms of the removal of Health Watch, I think the question is more, and this does play out in terms of AFTs for us. One of the questions that we were asked was, what does our governance look like moving forward, especially in the removal of governors? So my argument was, well, you've also now taking away the ability for an organisation to actually look at what is actually happening in place, because I think one of the benefits of Health Watch has always been through the lens of place and residence. What does that actually look like? And for those of us who work in multiple places or have multiple different types of patients, be they specialists all the way down to primary care, I feel that Health Watch has been helpful with that. And I think what we need to be able to articulate back is, in the absence of that, what does that actually mean, and how are we going to get the voice of residents? And I think there's quite a bit of debate at the moment around the usefulness of PPGs or otherwise. I think PPGs have been helpful for primary care in a singular bit, but if I'm honest, let's think of it as three very large organisations. We're going to need something very, very different to replace that. Now, I suspect we might want to commission, as NHS organisations, someone to allow us to hear the voice of our residents in a very, very different way, rather than something set up separately. But I don't know what colleagues would think about that. But I'm more deeply worried about that than sort of the broader centralisation bit.
There's a couple of bits on that I think it's just worth exploring possibly. One is that I think just because we don't have an ICB in the room, the virtual room, there's definitely a resourcing issue. So they've had their resources cut hugely by 50% over the past year. The current proposal is that they take on some of local Health Watch's functions. And there is, if they're going to be asked to do that, then I think the resourcing that's currently there for that needs to go for them. That hasn't been confirmed so far, so that does need sorting out. There is something about whether the patients need an independent voice. So if you are a patient that has a story that you feel needs to be told, one of the reasons why Health Watch was set up as it was that it was independent of the system and there basically purely to advocate for you. Whereas what we will be asking of those patients and their families and carers and things in future is that they engage with the system, which is a different thing. And there may be advantages in terms of, if that works, getting that feedback closer to the source in terms of the department or the ICB, but there's a bigger hurdle to clear, isn't there, as a patient? what I was actually going to just come back to your point on, James, is that I think we've got 2 non-foundation trusts and 1 foundation trust represented. So there is, as you abolish councils of governors and take out the Health Watch in its current form, how have the non-FTs in the room engaged with their communities in the absence of councils of governors? And is there something that you would want to share with FTs about how to do that in future?
I'm happy to jump in first, Adie. I mean, yes, there's something about, we've invested a lot of time and energy and effort in reaching out into communities. So just going out and listening and understanding. And I think that reflects the huge diversity of communities that we've got in East London, the level of deprivation and the huge health inequalities that we've got. We see it as a core part of our business to do that. So why wouldn't you? And I'm sure it's pretty much the same with you, James. To remove a level of governance, you're still going out and talking with communities, etc. So there is something there about just managing stakeholders and having that external view and that external voice. And in doing so, you start to create better solutions, you start to build trust, you start to co-design, etc., etc. There's far more that we can be doing, but we have invested a lot of time and energy into that and have found that really helpful, and we get a really good return on investment of that time and energy. So yeah, of course, we're going to be continuing that. There probably is something about the more formal edge that Health Watch can bring, which I think you were describing earlier, James, which is the bit that's missing. And how does that fit with our own PALS work? And frankly, I find it hard enough to navigate the NHS sometimes, and I've been working in it for 30+ years. So for a lot of people outside of the system looking into an incredibly complex system, how do they do that? And which bodies can help people navigate that system?
So I would agree, and I think it is. If we think, and I'm not suggesting that it's easy for you at all, Anne, because having worked in your organisation many years ago, it's a very, very different place. But I think, so if you think through, you can talk about to people what services look like in a place, because it's a logical, cogent conversation. Once you start saying, but what does your health and care look like in general? I think we open up a very, very different thing. And this is the bit that worries me even more about some part of this, David. We have to target those people who are unlikely to ever talk about the outcomes of their health and care. And this worries me even more, because that entire group of people are more likely not to engage with statutory organisations, and even we could be, imagine Adie, Anne and I went out and had a conversation. We could probably be the loveliest people in that conversation ever, but by virtue of who we are, what we look like, our obvious wealth that sits with us and before us and behind us, we're running major organizations. People are just not going to engage in the same way. So I'm worrying more around people who have intersectionality in the bottom 2 quintiles of deprivation about their ability to engage, which is why I think, Anne, you're absolutely right. I think as an organization, you have definitely leaned into that, because you have to. I've been having conversations and value thoughts from colleagues around the use of health and wellbeing boards. So I think the legislation might actually call this out a little bit clearer. So I don't think health and wellbeing boards have ever been used in the intention for which they were created and set up, mainly because they've been taken in some places as at best, officers not wanting to be scrutinised and throwing the NHS under the bus in front of their members. And so we've got 14 of those just in London alone, and then I've got 4 in Hertfordshire as well. So we've got 18 health and wellbeing boards. Yay, it's fun. But I think there's a real ability for us here to actually require health and wellbeing boards to actually hear the voice of their residents. And there is potentially something the local government could do in this place, because you could actually take a paper that says, and we have asked our population what they think about health and care. And I think this is going to be really, really important as we think about neighbourhoods, because as organisations, we can ask our patients about the care that they're receiving or what we're doing or not doing. There is a broader question that needs answering, which is, are you in control of your health and care? Do you believe that you are a sentinel individual in that delivery of health and care? And do you fundamentally think your health and care is better today than it was 2 years ago? Now, that we could ask that as NHS organisations, but we'll be asking it through probably a narrow lens, or it will be perceived as a narrow lens, as opposed to the broader conversation. I think this is the bit where, for those of us who will be leading in places, I think we're going to need to get into that. And this sort of stacks into the, who is the AFT? What is an IHO? Is it the responsibility of the IHO to ask this? Is it the responsibility of the commissioner to do this? So I think it's slightly all to play for.
Interesting, yeah. Obviously, some interesting points there. Looking at obviously the importance of reorganisation being done from the bottom up rather than the top down, and obviously getting the patient voice there. And that's I've heard obviously the argument that it's very important to wrap services around patients and certain patient conditions such as frailty, rather than looking at very much from the other direction. Would anyone like to
Yeah,
comment?
and certainly that bottom up piece and the engagement with our local communities, the work of the voluntary sector organisations being absolutely key to that, because they're the grassroots organisation that understand those communities, particularly those intersections, and are trusted voices. So our work with those organisations, I think, is key to this as well.
Anyone else like to add on that? Or?
So I'd just add on both of those, if that's all right, Lee. Just in terms of, I really liked what James was trying to get across there in terms of changing the narrative from like what's the matter with you to what matters to you, you know, on the wider population piece. And actually, we are big organisations, and we are really hard to engage with. So where we've got probably most of our feedback back is not necessarily through the PPGs, as you said, James, which is primarily through the primary care lens, although they do stretch out into community, but mainly around the voluntary sector. And actually, how do you engage that sector who do have like deep roots into these places and communities? The bit that I still worry about is that we talk about the engagement when we're changing things. How do we get the engagement of understanding what needs to change?
That's great, James. I think you'd like to come in on that. Yeah. So this is the therapist coming at me. I think we need to structure this in a way which is we absolutely require a legitimate conversation with our patients, who are patients, around the care that we deliver and they are receipted of. Because if we don't know that, we fundamentally won't know whether or not we're actually delivering good care to people. And that is the responsibility of of anyone providing an NHS contract. But we shouldn't confuse that with stepping back and asking our residents around their health and care. And the NHS has failed to do that because we've only really done it through a narrow lens. And I've been talking certainly with National and internally around, as we step into being an AFT and wanting to move forward, what if actually we suspended reality for a moment and thought that patients weren't residents, and they weren't even residents, they were policyholders. If we assumed that every single resident in this country actually had a policy for their health and care, which is actually correct, what are the questions we would ask them around whether or not we, as the insurance agent, was delivering for them, which is separate from, was that intervention good? And we've got to be able to do those two things together. So I think think the people who are going to be leading in this space need to be able to separate those two things out. And you would want to commission something. Now, if you look, David, I think you might know this, Lee, possibly not, but and Will probably, Adie not. When we've done the deliberative exercise in London, we asked 100 Londoners to come together. They were matched in terms of deprivation, gender, ethnicity, and boroughs. So we actually had a really interesting mix of people, and we walked through 2 sets of 2 days going through what are your health and care needs and what are you happy to debate. So we've actually got a consultative forum, and if you're going to do this, I think you're going to need to create a forum that is a known entity in which to consult with, because otherwise all we're going to get is, I'm not happy about my podiatry appointment. And it's not that, because that's a different route of conversation. So I think we as NHS organisations need to think how they're going to step into this. Query, David, whether or not the ICB does that. And if the ICB is going to do it, they're going to need to have, I think they're going to need to commission a group of people to do this work, not just anyone who'd like to turn up.
Yeah, really interesting point. It's not something I was aware of, actually. Is that done on a London level, or is it lower than that, James?
No, it was done on a London level, because we had some very specific questions we wanted to ask, and it largely related to data, use of data in our data environment. So as we step into having a secure data environment, so Barts is lead, we are one of the leads. We need to be really clear that the decisions we are taking as chief executives mirrored what our public felt was acceptable. So not surprisingly, everyone thought that we shared all of our data anyway. So I think, we don't. So like all of those sorts of things. So at least we have a voice to say, no, but we have actually engaged with this.
That's really interesting. I think just a couple of thoughts. I think there's a thing about scale, and there's a thing about the reason why the bill is as it is that ministers would say, we hear all day and all night from our from voters about what we think the NHS ought to be doing, and they would say that it's what we ministers are there to do is to take decisions, or arrange for decisions to be taken in response to the needs of the population for whom they have statutory duty to arrange the healthcare services for, right? So there is a political answer, which is that the ministerial accountability and responsibility for the service is the sort of is the connection, I suppose, between the services leadership and the people it serves. However, we all know that that services are actually commissioned and arranged at a more local level than that, and for individual people are experienced on a much more local level than that. So the ministerial accountability for the service is important, but it only gets you so far. In terms of whose job it is, I don't think it is. I don't think it's clear on the face of the bill that there will be sort of duties to do anything like what you've just described, James. But I think there is. It sounds really important and really powerful, and I guess the vital thing to do is to do it at the scale that makes sense for how services are arranged and where people live their lives. And in that sense, I wonder whether London might be a little bit of an anomaly, because it's an enormous population and is an area that people who live in London sort of identify with, but elsewhere in the country it might be important to do that at a slightly sort of more local, lower scale. And I have questions about. It's interesting, we had a conversation about health and wellbeing boards, which are very sort of, what we used to call place-based, 150 odd of them. And then there's an ICB's point, which we've just made bigger and like deliberately larger and arguably more remote from where people are actually living their lives.
James, you want to come back on that quickly?
Yeah, so I think this is why I think our government structures are actually really, really important. So in London, boroughs are boroughs, but no one actually says that they live in a borough. They say they live in a specific area. or you are in London. So it's either of those two things. And I think the ceremonial counties, I'm going to deliberately refer to them as ceremonial counties, they are obvious things. If you're in Cornwall, you're in Cornwall. It is not Devon, it's not Dorset, it's Cornwall. So actually us thinking about what the nomenclature of this and the ceremonial status of those places is really, really important, because if you're not doing it at that scale, I think anything less is also too small. I think there is something to think through what the relationship is with the unitaries, as the unitaries come into play, what that looks like. I do think it's odd where we've got in Hertfordshire, we're going to potentially could have had one unitary, and now we're going to have 3 potentially. It's like, what, this is ridiculous. Just going back to your point, David, and I think this is sort of the follow on through. The first question about are we being centralised? Yes, we are being centralised. We are being put under direct control from the Secretary of State in right of executing that very governance point that you've said, which is they have a responsibility to commission and ensure the delivery of the NHS. The query is, how does that get translated down the chain? Because whilst ever no resident is enrolled in an NHS organisation, no sovereign officer is fundamentally accountable for that care. So as the Secretary of State is trying to execute this governance, it becomes diffuse, because I'm responsible for my patients. I'm not responsible for the health of the population. Now, I think that should be altered. I think we should create organisations and everyone should be enrolled in an NHS Trust. That doesn't mean that they're always providing the services, but this is your named NHS organisation for which is responsible for your health and care, because otherwise you're never going to be able to tie those two extreme points together.
That's great.
Yeah.
Thanks for that, James. Yeah, we obviously we've spoken a lot about the patient, which is great. Obviously, what we should be doing. I just wanted to maybe finish just by looking at what the health bill says about the single patient record, and just get your thoughts on how empowering that could be for the patient. Would you like to start on that one, Anne?
Yeah, I'd love to. So yeah, I think this could be an absolute game changer in terms of patient ownership, or in terms of individuals' ownership of their health in the way that James was just describing, but also just in terms of the data pool that it gives us for research, for innovation, etc. The opportunities are absolutely immense. So as a patient, having a single patient record is kind of expected. So the deliberative exercise that James was outlining earlier that happened in London came up with exactly that result, that the patients are saying, you're not doing this, that doesn't make sense. But also they were saying, okay, and if you NHS want to sell that data to make money, that was okay as well. That was one of the surprising results that came out of it. And I think that there were some red lines in terms of who to sell that to and how to use that data. And I think that, recent discussions around data and data management and who owns data and various different companies being mentioned around that, I think has been makes it a difficult issue because of geopolitics. Certainly it's a big issue for us locally in terms of who are the companies that are running these organisations. So we have to be incredibly careful about how we manage data so that we don't lose trust of that. But I think patients kind of expect it, and therefore it makes it the right thing to do. The question is who's benefiting from it. So it's the right thing to do, who's benefiting. I think doing it is going to be really difficult. So was it 2028, I think, was the expected point at which this would happen? Yeah, I'm dubious, I have to be honest, because it's so complicated.
Adie, could I bring you in on that one?
I was just going to add to Anne's there. So I think everyone outside of the NHS organisations expect there to be one patient record that we have we have sight of and we utilise across, and so we make the best decisions, or at least people have less less incidents or less time having to retell their stories, etc. to get things across. So I think the key thing will be the ownership, and I like Anne's point there in terms of who is benefiting from the shared record, because if it's a slippery slope if it's an external organisation that's profiting from a shared patient record more so than actually the improvement in health and care that comes from that.
David, could I go to you next?
Yeah, I think like we hear similar things from our membership, which is that patients find it baffling that information can't be shared, and find it really frustrating when they have to share the same information over and over again, or when clinicians are in a position where they have to take a decision when they don't have the information in front of them that you would expect them to have. And therefore there's huge support for the single patient record. There is some concern among the GP-led organisations in our membership that the information from the GP record that gets used in the single patient record is that they're not basically held legally liable for anything that goes wrong with data that sort of originated with the GP practice, and that really needs to be sorted out and to be made really clear. That's not impossible. I don't think we've quite got the clarity on the face of the bill yet that people will be looking for, but it doesn't seem impossible. But it really needs taking seriously, because one of the two things that could go wrong with this are that you trust in politics is really low at the moment, and if the answer given to GPs is "don't worry, it'll be fine, just take our word for it," I don't think that's going to fly, and then there's a risk of a lack of clinical buy-in for it, which could scupper the project, which would be a disaster. And then also trust among the public and politicians is low as well. And I think most people, particularly patients, would see the benefit of this, but what you don't want is a mixture of kind of campaign groups, and particularly sort of maybe more broadly founded concerns about, as we've already said, who might be, which companies might be involved or might be benefiting from it, leading to a loss of confidence in the project. That's kind of what happened 10 years or so ago with care.data, and we wouldn't want the same thing to happen again. And I think that for that reason, on the second point, it's really important that the discussion about this in Parliament is responsible and proportionate and measured, and people don't jump up and down over egging certain points for political reasons, because that could skew the debate, and it could have a big influence on how this lands with the public, and if then all of the opportunities this offers could get lost, and we really need that not to happen.
That's great, thanks, David. Then could we finally just have a thought from you, James, on the single patient record?
So if you believe in free social healthcare for the benefit of the population, it is inconceivable that you would not have a single record that is owned by the individual patient, and that we as providers pull up information that we're required to deliver that care, but basically we are pulling it up from the individual record itself. I think we need to suggest to the government that they need to set out a clear and compelling argument that makes it irrefutable for that not to be the case, and that they need to therefore sit back and also direct, with the points that David has said, what that actually means for everyone. So calling time on all data providers and their inability to share information, not acceptable moving forward. That we change the architecture and infrastructure of the way information is reported and collected, that we own it as an NHS. We might have a provider who's doing the background work for us, but it's ours. But I think if we do not describe what it is, its purpose, where it sits and who owns it, we will invite the political debate. And it's not going to be between Labour and the Tories. They are both consistent on this one point. It will be the extremes of politics that will get that. And I think that's going to be even more difficult, because all anyone would need to say is this is route for basically individual registration, because it is individual registration, because we would all have our own NHS number, because part of it means no MRNs moving forward, everyone on their NHS number. Now, as an Australian, I still have my Medicare card. I have to show it when I go in, and there's nothing wrong with that. And I think we've got to play this out. And I think they've got to be really clear what it looks like. But I'm definitely for it.
That's great. I think sadly that's all we have time for today. It's been a great conversation. Thank you all for sharing your thoughts and insights. There's clearly a lot of work to be done on the how of this policy, and we look forward to seeing how it evolves as it goes through Parliament. But thank you again for your time, and goodbye. Thank you.